unmute yourself.
Good afternoon, everybody. Welcome to this afternoon's Gastroenterology Echo, which is hosted by the GastroFoundation in association with Project Echo from the University of New Mexico. These sessions are held weekly on a Wednesday and cover a variety of gastroenterology topics. We have 61 registrations this afternoon, representing 13 countries, and I'd like to welcome everybody to this afternoon session where Prof. Martin Hale will be discussing a collection of upper GI malignancies that have come across his microscope in the last few weeks. Prof. Hale, over to you. I think I'm going to introduce the first patient. Mr. LN, who is a 60-year-old gentleman, presented to his general physician with initially pedal edema. He was noted to be in mild heart failure, secondary to anemia. His hemoglobin on presentation was sitting at 6.2. He was admitted, transfused, diuresed, and a request was sent for endoscopy for investigation of the iron deficiency anemia. On gastroscopy, a lesion was noted in the antrum. It involved the incisura and extended up into the fundus. There were areas of ulceration, and the edges were somewhat rolled. It looked very suspicious for a malignancy, and we took multiple biopsies from various parts of the lesion. These were then submitted to Prof. Hale for histological opinion.
Right, thanks, Bilal. So this case is still very much in the workup stage. We saw this case only yesterday, and we think it fits in well with another case that we're going to show you. So whilst we haven't worked it up fully, we can certainly give you a very good idea as to what this is. Right, so what we've got then, and hopefully everybody can see the histology. Can you see that, Bilal?
Prof, yes, we can. Yes,
great. All right, so we've got certainly plenty of tissue. We can see, for example, here that there is mucus-secreting mucosa, and if we look at this mucosa, by and large, it's fine. There's a little bit of an increase in the inflammatory component in the lamina propria, and there is another area where it shows a little bit of intestinal metaplasia, not on this particular section though. But you can see that there are multiple portions of tissue in this, and the majority of them show infiltration by malignant cells. And you can see that we've got this malignant infiltrate, and we have cells that are arranged in a glandular pattern, well-differentiated appearance. You can see, for example, in this cell, at least in this gland here, we've got nuclear stratification. You can see the cellular crowding that we have. And you can also see this quite bizarre pleomorphism, or this enhanced nuclear pleomorphism with big nuclei there and, for example, smaller nuclei down here. And there's a considerable variation in the size of these nuclei. Mitotic activity is readily apparent, such as you see there. And in fact, abnormal forms are also present. And there's another mitosis just at the bottom here. If I bring this up, and you can see again an abnormal mitosis. This is a ring mitosis, and there's another mitosis which has a more normal appearance. So for the most part, then we've got this tubular structure, and not actually sure about this particular portion. One gets the idea that this is still within the lamina propria. And I think that you can see that these cells here are inflammatory cells. And I think those of you who are histopathologists will recognize that that could easily be lamina propria. So the question is, so why is that important? Well, it's important from a staging point of view, and we'll go into that shortly. There are also foci of tumor necrosis, which is concerning. So, for example, here you can see that there's extensive necrosis, and as Bilal mentioned, there was evidence of ulceration, and this could also be part of that ulceration. So this is a concerning feature, because if it's just an intramucosal lesion, you would tend not to see ulceration. It's not absolute, but as a general rule, you tend not to see it. If we move down here, you can see that we're starting to see a little bit of increase in vascularization, which is concerning for possible deeper invasion. And then here, for example, it then becomes more apparent, excuse me, we've got these cords of cells here, more of a trabecular arrangement. Some of this material, I think, is probably a bit of collagenization and fibrosis, but we'll come on to that, as I said, in more detail. When we look at the next block, and we've got plenty of tissue, which is great. If we look, for example, at this, these biopsies here, you can see that we've still got this tubular pattern, and in some areas there is more of a trabecular arrangement. This sort of thing here, for example, where you've got compression of the glandular structures. But I think importantly, the stroma is now starting to look much more desmoplastic, and I think that there is increased collagenization, and here and there is evidence of smooth muscle. So if we look here, for example, this is a smooth muscle fascicle. I think it's difficult to decide from where that is derived, whether it's from the muscularis mucosae or whether it's from the muscularis propria. Probably just by the size and dimension, probably from the muscularis mucosae. But that finding on its own suggests that, in fact, that you've actually got tumor which has now progressed beyond the lamina propria and is probably sitting in the submucosa. So, and then if we look here, we can see greater evidence of that. For example, here you've got a tumor nest. That here there's much more desmoplasia and reaction. I think some of this is smooth muscle. And I think this is concerning for certainly extension into the submucosa. I think we can be fairly sure about that. But possibly also this is smooth muscle. And these are quite thick bundles of smooth muscle. And that suggests that this is probably derived from the muscularis propria. So it may be deeper than we initially thought. So what then is the diagnosis? So this is gastric adenocarcinoma, and we'll talk about the WHO classification shortly, but this would be the tubular variant of adenocarcinoma. Now, the important thing is to make sure that it is of gastric origin. So we look at the cytokeratin profile, and this is the cytokeratin 7, and you can see that the CK7 the CK7 shows focal positivity, as you can see here, and also there. And then the CK20 is positive as well. Now this is a little bit of a distraction, as it were, because ideally what you would like to see is a tumor that is CK7 positive and CK20 negative for gastric cancer. So, and the reason for that is because this could be a metastatic lesion. So we will now have to go ahead and do another marker of large bowel origins such as CDX2, and hopefully that will be negative, which will then confirm this to be of gastric origin. I think clinically it clearly is a gastric tumor. What I want to do now is also show you the small focus of intestinal metaplasia that we also found, for example, there. And as we know, intestinal metaplasia, you can see these goblet cells is a precursor of progression towards gastric cancer. I think it's important to say that there's no obvious dysplasia in these small portions of small bowel mucosa, at least of mucus-secreting mucosa. We're also looking at, we've got to do the prognostic information as well. And if we look at the mismatch repair genes, and I've literally just got these back this afternoon, just a few minutes before the meeting, and you can see that that there is no evidence of mismatch repair. In other words, the mismatch repair genes are retained. As you see there, you've got positive intranuclear staining. And the control is always the lymphocytes, for example, in the adjacent tissue, because those are benign. So you can see the positive staining there and the positive staining in the neoplastic cells. So that is MLH1. This is PMS2, which is also shows retained microsatellite function. You can see that again, well demonstrated. And then this is MSH6. And once again, you can see that that is also retained. So this is tubular carcinoma then of gastric cancer of the tubular carcinoma type. So I think what I should do now, Bilal, is go on to the next patient. Shall I do that?
Yes, please, Prof.
Okay, so now what I'm going to do is I am just going to share my screen again.
So this is a patient that presented via Charlotte McDecker to Prof. Hale. So I'm not too clear on the clinical history, but it's another form of gastric carcinoma, and we thought it would be worthwhile contrasting the two types.
Right. Can everybody see that?
Yes, we
Can you
can.
see? Great. Okay. Right. So this is Mr. CC. He is a 40-year-old man, and he presented with a previous history of hemorrhoids that have been previously banded. And when he presented, he gave us a history of a 9-month duration of diarrhea, loss of weight, and obstructive symptoms. And the assessment at that time was that he had Crohn's disease with stricture formation. He underwent colonoscopy, during which a stricture was found at 10 centimeters. The stricture appeared edematous but looked benign, and there was no evidence of ulceration. Gastroscopy at the same time showed thickened mucosa and gastric folds. So the first thing I'm going to show you, which was a completely, if you like, incidental finding, and that was one of the biopsy from the colon. And I know this is GI pathology, that is upper GI pathology, but I'm just going to show you this to dispense with it. This is an interesting finding, and that is that so if we look at this colon, you can see that first of all, there is some pathology in it. And I think if one looks at the architecture, by and large, the architecture is fine. You can see that the colonic crypts are regular in distribution, which is a very important finding, particularly when you come to diagnosing idiopathic inflammatory bowel disease. But you can see that there's a little bit of busyness in this area here. There's not much in the way of budding, And if we go down and have a look at this, you can see that there is a cryptitis going on here. You can see that the crypt has largely been destroyed, and instead you've got this infiltrate of neutrophils sitting in the actual crypt itself. So this is a typical crypt abscess. There are a few eosinophils associated with this, and there are a few neutrophils. So on its own, this finding really would be that of what we would call a self-limiting colitis. You can see that there's also a little bit of pigmented ceroid pigment and probably a little bit of iron in this. Nothing really too much to worry about there. But then the other thing that we also have is down here. And here we have a small granuloma. You can see that there. And you can see this is a multinuclear giant cell. And sitting right slap bang in the middle of it is the remnants of a bilharzial egg. And this is schistosomiasis, colorectal schistosomiasis, or intestinal schistosomiasis, typical appearance of a degenerate egg. And as I said to the registrar at the time, how would you distinguish between Manson-I and hematobian infections? And they said, well, you'd look for the position of the spine. And that, in fact, is okay if you're looking at the whole egg. The problem is that histologically, we're not looking at the whole egg. And if you can just picture in your minds that if you have a schistosomal egg with a lateral spine and you section it obliquely through that egg, the lateral spine becomes a terminal spine. So you can't use histology on its own to determine the H&E, that is, to determine the species. What you can do, though, is a Ziehl-Neelsen stain, because the eggs of schistosoma mansoni are ZN positive. Now, these days, everybody gets what's the drug? Praziquantel. And, they sort of get it as they go through the door. And so it doesn't really matter. But in the old days, in fact, it did matter because there was different therapy for the different species of parasites. So it was important to make a species identification. It's also important from the point of view, I mean, it's of interest, obviously, the ZN would be positive in this. And unfortunately, when we cut the deeper sections for the ZN, it was cut away. But that's I'm quite sure that that's a Manson-I egg. There's also evidence of melanosis coli, for example, in that as well. Right, so let's move on then. So let's move to his stomach. So you'll recall that his stomach did appear endoscopically abnormal. And this is a very good teaching slide. First of all, it was brought to me because the person concerned was unsure as to what to call this. And the thing is that this particular entity can be missed so easily by histopathologists. And this is a biopsy from the mucus-secreting mucosa. It's a very nice biopsy, nicely orientated, nicely cut. And you can see that the architecture, there's something going on in this. And it's very easy to say, yes, okay, this is a chronic gastritis, and send it out, particularly, for example, if it's a Thursday, if it's a Friday afternoon. And I think there are a couple of sort of mantras that you don't look at melanocytic lesions on a Friday afternoon because you may miss the nevoid melanomas. And likewise, you shouldn't really look on a Friday afternoon at rather cellular looking gastric biopsies. And the reason for that is typified by this case. Because when you look down here, you look at these cells and you say, yeah, this is just inflammation. This is just inflammation. And then when you look around a bit more, you can see that these cells sort of merge, if you like, with the rest of the lamina propria. It also appears edematous. You could easily see this sort of thing merging with this here. And then when you have a closer look, you think to yourself, yes, okay, these are probably just histiocytes. Okay. Cells are relatively uniform. They're a little bit hyperchromatic. That nucleus there looks as though a rat has taken a piece out of the nuclear membrane, so-called sort of nibbling away, which is a feature of malignancy. And similarly with that nucleus there. Then you look at this cell here, and you can see that there's a clear vacuole in the cytoplasm. And similarly, there's something going on there too. Now this is high drive, 400 times magnification. So you can see how easily this is missed. And here we've got a cell which is now starting to show fairly typical features of signet ring morphology. You've got this crescentic shaped nucleus with this large intracytoplasmic vacuole. And this is the old, what we used to call signet ring adenocarcinoma of the stomach. And we'll talk about the new classification shortly. And here again. So this is an entity that is often missed. And I can remember during my career, we've seen several cases where gastrectomies have been done. And I mean, I can tell you that I had personal experience of this many years ago. And in fact, from a diagnostic point of view, it really threw me. Because what happened was I was shown a case like this. I was at Barra and working on my own, and one of the registrars who was about to write their exams said, what is this? And he told me about it, and I said, no, I disagree. This is not a gastritis. And I said, I think this is a signet ring adenocarcinoma of the stomach. Anyway, what happened with the long story was that the person concerned, I said he was a good registrar, was quite confident in making the diagnosis. I suggested bringing it here into Johannesburg. It was brought into Joburg. Nobody agreed with me. Everybody disagreed. So I thought, okay, well, send it out as a benign ulcer. And then the following day, the gastrectomy arrived, and it was absolutely riddled with gastric adenocarcinoma of the signet ring type. The story didn't end there. I was quite shaken from a diagnostic point of view, I must say, because all my criteria had been just cast out of the window. The next day or 2 days later, another biopsy arrived from a different patient, showed exactly the same thing. So I said, well, you called this last one benign. This one has to be benign. And it wasn't. It was malignant as well. And I've never forgotten that. And it really was a sentinel lesson. So everybody's missed these in the past. They've called them gastritis, and they're not. This is a signet ring carcinoma. And it's a particular problem if there's evidence of ulceration, because when you see transmural ulceration, at least transmural inflammation underneath an ulcer, you must always think of signet ring adenocarcinoma. So then what about the immunohistochemistry on this case? Well, the immunohistochemistry was interesting because, first of all, this is the Alcium blue PAS stain. And so just to put you in the picture, we do a combined Alcium blue and PAS stain to pick up what we call the sulfated mucopolysaccharides that you get with intestinal metaplasia. So the PAS picks up the neutral polysaccharides or the neutral mucins. As you see here, you get this magenta color, whereas the Alcium blue, if you have an acidic mucin, picks up the mucin, but it stains blue. And if you look at this here, you can see that this mucin is blue. All right, so you compare, for example, I think this cell is actually producing a bit of both, but you can certainly see that there's a blue tinge to the mucin in these cells compared to the mucin in these cells here. There's a distinct difference in color. And for example, if you look at that there and that there, okay, completely different mucin production. This is also a malignant cell, but this just happens to be producing neutral mucins. So these are the mucins that are being produced by the signet rings. Absolutely classic. Now, everything that you see we always say nothing is absolute in medicine. And this is also true because you also get a signet ring lymphoma, which can look just like a signet ring carcinoma. So when we look at the keratin for this is positive. And here you can see, for example, now, once this image builds, you can see that you've got the inbuilt control of the benign mucinous glands at the periphery. But all these here, these are the neoplastic cells or the malignant cells, and you can see the extent of this infiltration is literally raining up, if you like, or raining down from the mucosa into the muscularis mucosae below there. So this is this just confirms the epithelial nature of these cells. Now, the other thing that I just want to mention as well is, once again, for the histopathologist, a good mantra to sort of remember is that mucophages do not exist in the stomach. Okay, so if you adopt that as a mantra, you're unlikely to make a diagnosis of, or at least to make a mistaken diagnosis of calling them benign mucophages. And this is a CD68, if I can find it, here we are. And here you can see there are histiocytes, for example, present in the lamina propria of this biopsy. But if we look, for example, I'm trying to find a decent signet ring. So I think that these are okay. So if you look here, these are the neoplastic cells, these are the malignant cells. And these are the malignant cells at the base of that biopsy. And you can see that they're all negative. Okay, so those are not mucophages. And then this is the CK7. And this is positive. And you can see good going, strong positivity of these neoplastic cells. So that's a very good lesson. And it's worthwhile remembering that signet ring carcinoma is a very difficult, or can easily be missed. But if you think about it, you won't miss it. And everybody makes that mistake. So that's a great case. Now, what I wanted to do was to use these two cases just to bring everybody up to speed with the new classification of gastric adenocarcinoma. All right, can everybody see that table?
Yes, we can.
Great. Okay, so some of us, maybe not many of us, will remember that we used to talk about gastric adenocarcinoma according to the Lauren classification. And that Lauren classification was used for many, many years. In fact, really up until just a couple of years ago, most of us used the Lauren classification, which divided gastric adenocarcinoma into these types: the intestinal type, the diffuse type, and the mixed type, and various mixed categories such as you see here. The diffuse type was a signet ring cell type, and people, as histopathologists, called the diffuse type and the signet ring adenocarcinoma to be the same thing. But these days, what's happened is that, like everything, things move on and change. And sometimes, one wonders why. Well, I think in this particular instance, I guess it's a bit of a misnomer to call gastric cancer an intestinal type, because it's not an intestinal type. It is actually of gastric origin. So the WHO classification then, the 5th edition of digestive tumors of the digestive tract, divided these into, at least renamed them, into the papillary, the tubular, well differentiated, the tubular, moderately differentiated, and then the tubular solid. Now we've got the tubular example here, and the recommendation is that we call the tubular well differentiated and the tubular moderately differentiated as being of low grade. So we're tending to divide things now into two sort of prognostic grades, if you like, the so-called high grade and low grade tumors. So these would be low grade tumors, whereas the tubular solid one would be a high grade lesion. Then, of course, you've also got the papillary tumor, which is a rare tumor, and that also fits into the low grade category. Then we have the diffuse or the signet ring carcinomas, and these are poorly cohesive, and those are high grade lesions, and they often have a fairly poor prognosis. And the problem is that many of these patients, by the time they present, in fact, have advanced disease. And then you've got these other types. You've got the mucinous type, which is a tumor which is composed primarily of mucinous secreting malignant cells, and usually has to be 50% or more, the mixed type, and then a whole lot of varieties of rare tumors such as hepatoid variants and so on and so forth. Right, so those are the rough sort of incidences. The tubular carcinomas by far are the commonest, followed by the poorly cohesive tumors or the signet ring types, and then the variety of the other tumors, as you can see there. So tubular carcinoma then is the commonest. So this then, by virtue of its presentation, its histological features, would be tubular carcinoma well differentiated, or well differentiated and by inference low grade. This is what Linitis plastica, the old Linitis plastica, looks like. And this is also from the WHO book. And here you can see prominence of the rugae. And it was interesting that in this particular patient, prominence of mucosal folds was identified. And then I want to draw your attention to these photographs here, because you can see that the wall of the stomach, so this is the mucosal surface, this is the adipose tissue on the external aspect, and you can see this marked thickening. And notice also the accentuation of this fibrous connective tissue. You can see these fibrous connective tissue septi, and that happens because of this infiltration of this tumor along these facial planes, and the fascia responds accordingly and causes this extreme desmoplasia. There's a bit of ulceration as well, and usually what happens is that, often these areas are biopsied, and there's a little bit of inflammation on the surface. This arrow there corresponds to that arrow there, and then what happens is that the histopathologist misses the infiltrating tumor which is sitting down there. So yeah, I think those are two very good examples of the different types of adenocarcinoma. And then from a prognostic point of view, stage remains the most important predictor of 5-year survival. If it's a T1, a PT1, in other words, confined to the mucosa, and provided there are no nodes, then it's a greater than 90% year survival. But other molecular factors, as we do these days, HER2, EGFR amplification, microsatellite instability, and EBV, all those either modulate the therapy that these patients get, or have a small prognostic prediction capability. Okay, Bilal, thanks. Over to you.
Thanks, Prof. Yeah, so those are, as you pointed out, by far the two most commonest gastric cancers. Mr. LN, the tubular adenoma patient, underwent a CT scan after our endoscopy, and luckily for him, it doesn't appear that there seems to be any positive nodes, at least radiologically, and there are no clear metastases either. We've referred him to the oncologists to start neoadjuvant chemotherapy, and one of the upper GI surgeons will be consulting him today to put in place his further treatment plans.
Yeah.
The next case that we have to present is Miss SB. Sorry, I just want to get how old she is. She's a 51-year-old lady. Initially came in with, presented with metabolic syndrome, but a history of diarrhea, altered bowel habits, not necessarily silver streak stools, but diarrhea nonetheless, and significant loss of weight. On clinical examination, a hepatomegaly was noted, and it was a tender hepatomegaly. Patient was sent for a sonar where multiple target lesions were noted, suggestive of a possible metastatic lesion. Bidirectional endoscopy was performed, and this was negative. A biopsy of these lesions was then performed, and that's where I'll hand over to Prof. Hale.
Right, thanks, Bilal. So this was another interesting case, and it's amazing how this particular tumor presents almost as a silent primary. And the other silent primary that we also talk about as histopathologists is the renal cell carcinoma. Right, so here then is the liver biopsy. And can you see that, Bilal? Cheryl?
All good, Prof?
Yes, we can.
Okay. All right, so what we've got in this liver biopsy, then we've got it's a good biopsy, plenty of tissue. And you can see that as we go through this, one can identify that there's extensive fibrosis in these cores. And when you see this, there is one tumor that you think about, and that is cholangiocarcinoma. Now, the problem is that there were multiple lesions in this particular patient's liver, which tends to steer one away from, a primary in the liver, but nevertheless you can, as you know, get multiple cholangiocarcinomas in the liver. And that really comes about because of the field effect. But what is characteristic of cholangiocarcinoma is this extensive desmoplasia. And really we've got these sort of sheets and sheets of fibrous connective tissue. And then when we look at it more closely, you can see that the cells in many areas have a pretty benign looking appearance. Look at this. We struggle often with these biliary lesions. Is this dysplastic? Is it malignant? Is it benign? And, if we just got this in a liver biopsy, we would be very hard pressed to decide whether this was dysplastic or not. There is a bit of variation in nuclear size, but on its own, probably not worth sort of investigating further, unless, of course, we saw this degree of fibrosis. So then how do we make the diagnosis? Well, that can be, as I said, very, very tricky. And the most important thing when we're looking at pancreatico or biliary lesions is to look at the variation in nuclear size. One thing about biliary lesions is that when you get ascending cholangitis, when you get pancreatitis, for example, in the head of the pancreas, which is obviously where adenocarcinoma of the pancreas also occurs, you can't use at least an apparent infiltrative pattern to make that diagnosis, because benign glands look infiltrative. So one of the things that we do, one of the things we're trained to do is to look for infiltration. Is there any evidence of infiltration. And it takes us years and years to decide whether something is infiltrating or not. And often people say, well, why is it, what features suggest that it's infiltrating? And often we just have to say, because it looks like it. There's no real way to describe what infiltration looks like. You've got to look at the relationship between the cells and the adjacent stroma. So with biliary pathology, then we don't have that luxury, if you like, to decide whether something is infiltrating or not. So when we look at these cells here, and you can see that we've got these nests of cells, and in some areas there is single cell infiltration, for example, this sort of thing here. And you can see there's considerable variation now in nuclear size. You've got these big cells and smaller looking cells. And the rule of thumb that we use is to decide whether there is fourfold variation in nuclear size. And if we have fourfold variation in nuclear size, then we are happy to call that malignant, whether it is of biliary pathology or whether it is pancreatic, in other words, ductal carcinoma of the pancreas. So let's see if we can see that. So we've got this nest of cells here, or a couple of nests of cells. And if we look at a couple of nuclei, if we look at this nucleus there, and we say, okay, that's the biggest one. There's another one there, which is also fairly large. Now, can we find a nucleus where we can fit 4 of those nuclei into either that one there or to that one there? And that's where the trick comes. So, for example, if we take this nucleus here, it doesn't make the cut. That's probably 2, maybe 3 at the most. So you've got to find these cells and say, yes, okay, well, maybe that one there, possibly that one there. There's a nucleus there. Can everybody see that? Can we fit 4 of those nuclei into that nucleus there? And I think the answer is yes. Can we fit 4 of those nuclei into that nucleus? Yes, okay. And then if we look through others, we could, for example, see, so we've got a nucleus there, for example. I think we can fit 4 of those nuclei into that nucleus there. So that then meets the criterion for neoplasia. And then together with the desmoplasia, suggests that this is a cholangiocarcinoma. So we made a diagnosis of cholangiocarcinoma, and we'll take it from there just now. But you can see when we come back to this area here, we've got these bile ducts here, and you can see how relatively regular these nuclei are. And I suppose, I wouldn't like to have my arm twisted to see if there's a 4-fold variation in nuclear size. I don't think there is, but certainly, there's probably a 3-fold variation, but no more. So we would have to then step back, calling that infiltrative is probably, that's probably a dysplastic duct that you see. And remember that with cholangiocarcinoma, you often get a field effect. If you look at these ducts here, for example, you can see that this duct again, this could well be a native duct which is compressed by the adjacent desmoplasia. And I think that's probably desmoplastic. So we've got this change through large areas of this biopsy. So how then, well, what are the next steps? Well, the next steps, obviously, to make sure that it is of upper GI origin. And when we look at this, this is the CK7, and you can see it's strongly CK7 positive, which is of upper GI origin. And it is CK20 negative, as you see there. Okay, so that is well and truly supportive of that, of cholangio origin. Of course, it could also be pancreatic. Have to bear that in mind. And then this is CDX2. And I mentioned that we're going to have to do CDX2 on that gastric biopsy just now because of the conflicting evidence between CK7 and CK20 in that tubular carcinoma. So this is CDX2. So this ticks all the boxes then from a cholangiocarcinoma point of view. So after that, Bilal, I don't know if you want to go on and mention what happened next at endoscopy, or should I just carry on?
Go ahead and carry on, Prof.
Okay, so the patient then ended up having endoscopy of the upper GI tract, and this is a duodenal biopsy. And here you can see that we've got duodenal mucosa, which for the most part looks okay. Okay, there's a little bit of villus atrophy there, but by and large, it's all right. That's this part here. But then when we look into the deeper aspects, we can see in the submucosa, we can see malignant cells. And we can see these cells here. These are all sitting in lymphatic spaces. And you can see that we've got the same nuclear pleomorphism, not quite as pronounced. But bear in mind that we've already made that diagnosis, so there's no need to make it again, if you will. And here again, this is the muscle. You can see this is muscularis mucosae there, and here we have these nests of malignant cells. And if you look here, I think you can see that there's a fourfold variation in nuclear size. I think you can fit 4 of these nuclei here into that nucleus there, and probably some of these nuclei as well. So elsewhere in the duodenum, we've got this sort of picture. And here you can see the villi, that's perfectly benign. And then when we look down here, one can see that, that we've got lymphatic invasion again. And one gets the feeling, for example, in this mucosa, for example, down here in these duodenal crypts, that we're starting to see dysplastic change. So this is an ulcer then that was in the region of the duodenal ampulla, and I'm quite sure that, that this is probably the primary site of the tumor. So she's got, unfortunately, a cholangiocarcinoma involving the duodenal papilla, Hale's papilla, and with metastatic involvement to the liver. Yeah. And again, more areas of dysplasia. You can see this variation. You see the hyperchromasia in the cells. And that brings me to the end of what I've got to show you.
Thank you very much, Prof.
Pleasure.
Yeah, I think those are some great cases. Just want to have a look here. So Wisdom's asking, how do we explain the diarrhea in the patient with the liver biopsy? So I'm not 100% certain, you know, whether this was related to the cancer or not, whether it was possible bile acid malabsorption. Unfortunately, this was not one of my cases, so I don't know the full details around the case. Mzamo Mbele is asking, afternoon, Prof, with regards to the first 2 cases, could you identify whether the tumor arose from polyps or pre-malignant lesions such as atrophic gastritis or intestinal metaplasia in the specimen submitted, and was there evidence of H. pylori?
So yeah, that's a good question. So both of them are good. I'm not sure why the patient had diarrhea. we'd have to go back and have a look at that. As far as Nzama's question is concerned, a good question, Nzama, because as you know, I mean, most of these H. pylori is said to be the most common pathogenetic mechanism for gastric cancer. So, it probably was HP related. We didn't see any Helicobacter pylori in the mucus-secreting mucosa. They are quite fastidious organisms, so I would think that they probably would have disappeared. We did see a small focus, as I showed you, of intestinal metaplasia, so we know that was there. Didn't see any dysplasia, didn't see any polyps.
Yeah. Just see any further questions. Anyone else want to put up their hand for any comments? Chris, do you have any comments?
No, thank you very much. All good. All good. Thank you, Martin. You worked hard today.
Pleasure. We see some interesting cases.
Yeah, fantastic. Thank you.
Vikash has got his hand up, Wisdom. I'm not sure if Wisdom's up.
Thank you very much, Prof. Hale.
Okay, Wisdom, you go ahead.
Thank you, Bilal. Thank you, Prof. Hale. I just wanted to find out a very interesting case of cholangiocarcinoma, and then it sounds like arising from the ampulla region. What was the indication for the gastroscopy? Was there obstruction, or was it a liver function test that were abnormal?
So as I said, Wisdom, this wasn't my case. I wasn't the treating clinician. I'm not entirely certain of what the clinical situation around the case was. I think initially it was because the patient had diarrhea and loss of weight, and considering the ultrasound that picked up the multiple target lesions, a malignancy was high on the cards.
Yeah, that's exactly it. In fact, what happened, Bilal, was that metastatic malignancy, as I said, was high on the cards. And then when we diagnosed it as cholangiocarcinoma, then the gastroscopy was done. Basically, I think to see if there was a lesion in the biliary tree. And of course, there was that focus of ulceration, which was biopsied.
Oh, okay. So the biopsy started, then came the gastroscopy.
Yes, yeah. The gastroscopy followed the liver biopsy, as I recall.
Thank you, Prof. Thank you.
Vikash.
Hi, Prof. Hi, Bilal. Thanks for a great session. I just wanted to make a quick comment on the second patient, Mr. CC, with Linitis pestica, or the signet ring adenocarcinoma. He's actually a patient that was managed by me initially, and just out of interest, he had this anal stricture, and he was assessed as being a patient or having Crohn's disease, but there were a few things out of keeping. That diagnosis was made in private, but he had a negative fecal calprotectin, he had some pelvic ascites, and his initial histology wasn't quite in keeping with Crohn's disease. That anal stricture, it was probed. I'm not too sure whether it's related to a previous hemorrhoidal bending, whether it's related to the bilharzia, but just out of interest, there are several case reports, not many, a handful, probably about 5 or so, of signet ring metastatic carcinoma or gastric carcinoma with mets to the colon and to the anal canal. And there are case reports of patients presenting as bowel obstruction, and on biopsy of the colonic specimens had signet ring carcinoma, and then on further review they found that it was actually gastric with metastatic spread. So we're not too sure what the etiology of that anal stricture is just yet. The patient is or has been admitted for workup and staging, etc. The other thing that he does have also, which is interesting, is ascites. And we're not too sure whether the ascites is non-cirrhotic from the hyperplasia over that we're seeing, or whether it's actually malignant ascites as well. So he's quite an interesting patient. He's fairly young with no risk factors, and I must say a bit of a surprise diagnosis. Although endoscopically he did have features, he had this thickened, abnormal-looking rugae, and yeah, that's where we biopsied him and picked up that diagnosis.
What's the SAG like on the ascites?
To be honest, I just got him admitted yesterday, and I don't have anything yet to give you.
Okay.
So I'm not sure what the SAG is. I'm not sure what the staging CT is yet. We're planning to
Sorry,
work
you
him
said
up.
ascites.
Yeah,
heading
sure.
down,
So I'm not sure.
heading down a road. Yeah.
I'm not sure if it's malignant or if it's
Perfect.
non-cirrhotic. We don't have a SAG or anything just yet.
Yeah.
So
It would be
Vikash,
unusual.
Vikash, I think you've made some very interesting comments, because certainly my experience with these tumors, as you said, young people, often young people, 30s and 40s, and by the time they present, they usually have, or often have, extensive intra-abdominal disease. And I think your point about the about could these strictures be due to metastatic disease, I think needs to be investigated, because I would, if I was a betting person, I would suggest that he's probably got disseminated disease with strictures.
Endoscopically, the mucosa in that anal canal didn't look very abnormal. It was quite tight. I was able to get through it with the scope. We did biopsy it, and there weren't any signet rings, but we are planning perhaps once it's a bit more worked up, perhaps an EUA under anesthesia, to have a look at that anal stricture, rebiopsy it, and look at the means of dilating it as well to give him some symptomatic relief.
Yeah, the problem is that the stricture is coming from outside.
Yeah,
Potentially,
it's a tough, yeah.
Infiltration from the peritoneum into the bowel. So
Sure.
you may not even on biopsy
Get it on biopsy. Yeah.
Yeah. It is such a sinister disease, this signet ring carcinoma.
Maybe consider an EUS of the area.
It's a bit tight to get an EUS scope up there, so we haven't. We'll maybe consider that afterwards. We were thinking about an EUA in theatre, and possibly even a diagnostic lab scope to put a lab scope in and look for peritoneal deposits. But like I'm saying, we're still waiting for a basic staging CT scan and assessment of the ascites. So we'll see how it does.
Prof,
say
Silanda Esau has asked if you could just go through that signet ring slide again to highlight why it's easily missed.
Yeah, sure, on the H&E.
Yes.
So what happens is that perhaps I'll tell you what I'm going to do is I'm going to put on the first patient first. So I'm going to share my screen. Okay, so this is the first patient where you've got the adenocarcinoma here, and this is, as we often say, this is a straightforward diagnosis. This is not a problem to make a diagnosis of adenocarcinoma. But if we look at the adjacent tissue, so these are the malignant cells there. And what you need to look at are these cells here. And these cells, and I'd like you to take a picture in your mind of these cells. You see these? There, all these cells. Those are all inflammatory cells. Okay, so using your inbuilt camera, you could take a picture of that in your mind, okay? So we look at that and say, yes, this is, as I reported it, this is desmoplasia, this is inflammation in the lamina propria, and it's a reaction to the tumor. Okay, so just remember that. Look at the size of those cells. So this is 400 times magnification. So now I'm going to go back to the signet ring tumor. They've taken that picture. And when you look at these cells here, you can see that they are very similar size. They're a little bit larger, but many of them, such as these down here, look at that there. That cell there, if anything, is smaller than some of those inflammatory cells that I showed you in the first case. So it's very easy to gloss over these, particularly if the mucosa is sort of full of them, because you can imagine that if the lamina propria has got a lot of these cells, that you'd say, yes, okay, there's a little bit of ulceration on the surface, and this is just a gastric ulcer, particularly if you've got that ulceration. So that's the problem, is that these are easily overlooked, particularly as well if there's a few other inflammatory cells, and these hide. And the clue to missing this, or to stopping you miss this diagnosis, is when you start to see inflammation that goes through the muscularis. And I think that this tumor here, I think this is getting pretty close to the muscularis mucosae. I think some of this might be smooth muscle. So the clue is when you see this, just think again. Could this be? Just ask yourself the question, could this be an adenocarcinoma or an infiltrating carcinoma? Don't just pass it off. You don't have to diagnose it. You just have to ask the question, because asking the question will make you think about it. Has that helped?
Very much so. Thanks, Prof.
Pleasure. You see, look down here. Look at this here. These are signet ring cells. These are malignant cells, but these are probably benign. But these are malignant. But these are benign. And you see how subtle this is. Look at these cells here. Some of these are endothelial cells as well, but these are benign cells. Okay.
Very good.
Great. That, I think, leaves it up to me to close the meeting then. Prof, I'd like to thank you once again for taking us through those cases. I'm sure everyone found them valuable, as you can see from the feedback. Vikash, thanks for chipping in and giving us additional information on the cases that you had. I'd like to thank then the ECHO University of New Mexico and ECHO India team. There is a feedback form that is available in the chat. Please complete this, as it does help us with future presentations. The recordings are available on the GastroFoundation website. Thank you again to the GastroFoundation and to our sponsors. Next week, Dr. Shrish Badri. Shrish was a pediatric gastroenterology fellow when I was attending the fellow meeting. We attended together. He subsequently moved across to the US, where he had an interest in fecal microbiota transplant. And he has now, I see, done very well for himself, as he is the Senior Medical Director and Head of Clinical Microbiome Science at Finch Therapeutics. He'll be discussing with us harnessing the therapeutic potential of the microbiome in IBD and recurrent C. diff infection. So that'll be next week, Wednesday, the 16th of March, and it'll be chaired by Professor Joel Watermeyer. Thank you, everyone, for joining once again, and of course, to our sponsors.
Thank you, Bilal. Thank you. Hello, Christian. Thank you for joining us every week. Nice to see you. Cheers,
Okay,
Martin.
thank you. Thank you.
Thanks, everyone. Thanks for
Bye-bye.
inviting me. Cheers then. Bye.